The topic today to be discussed is pharmacogenomics as a new basis for drug therapy. And to do justice to that, we have Dr. Awodele Olufunsho. Dr. Olufunsho is an associate professor and consultant toxicologist and pharmacoepidemiologist of the Department of Pharmacology, Therapeutics and Toxicology, College of Medicine, University of Lagos, Nigeria. He won the Professor AFB Mabadeje Prize as the best Masters of Science Pharmacology graduating student in 2004, Best University of Lagos PhD Thesis Award in 2009, Best Nigerian University Commission Doctoral Thesis Award in Pharmacy 2009, Best University of Lagos Researcher of the Year 2010. Dr. Olufunsho holds a Master of Public Health degree and a Doctor of Science degree with special interest in pharmacoepidemiology and herbal medicine, and safety respectively. He recently served as a toxicologist with the International Maritime Organization London on evaluation of hazards of harmful substances carried by ship. Dr. Awodele has published more than 100 research papers in reputable journals and attended several academic conferences in South Africa, India, United States, United Kingdom, and Canada. He has supervised 5 PhD candidates who worked on teratogenic potentials of some commonly used medicinal plants by pregnant women in Nigeria, modulation of toxicity of anti-tuberculosis medicines, modulatory functions of Napoleonavirus jelly, hook and plank extract on micronuclear and apoptotic factors in rodents, pharmacological and cytotoxic activities of selected medicinal plants used in cancer therapy, an evaluation of pharmacological and toxicological activities of hydroethanol root extract of Acridocarpus species. Dr. Olufunsho is currently mentoring 5 PhD scholars in different aspects of toxicology. He is a member of the National Agency for Food, Drug Administration Control Committee on verification of safety and efficacy of herbal medicine in Nigeria. He recently served as a consultant and reviewed and updated the National Pharmacovigilance Policy and Implementation Framework for 2019-2020. Dr. Olufunsho won the prestigious award in 2019 of the Society of Toxicology Global Senior Scholar Award, and he is the current editor-in-chief of the West African Journal of Pharmacy. Ladies and gentlemen, colleagues present online, I present to you Dr. Awodele Olufunsho. Doctor, you are welcome, sir. So
thank you, Dr. Joseph.
To you to have your lecture for 45 minutes, sir. Thank you very much.
Thank you, Dr. Joseph, for the honor of that good introduction. I appreciate that. I also want to appreciate Dr. Bello for constantly calling me and trying to fix an appropriate time for this presentation. And I want to appreciate the entire team of Pharmacy Department, University of Lagos Teaching Hospital. And to all participants, I want to welcome you to this presentation. Well, just as Dr. Joseph said, I'll be presenting on an important topic. It's an emerging area in clinical practice, the aspect of pharmacogenomics. And basically, I'm sharing my slide. I will be talking on pharmacogenomics as a new basis for drug therapy. Well, the major objective is to describe how individual genetic variations affect drug response. Well, this is what we currently have in clinical practice. You have same people having same diagnosis, being placed on same medication. And when this happens, there are likely going to be 4 outcomes. We may have these individuals having toxic response to the medication, but the medication may be beneficial to them. We may also have this individual having toxic response to this medication, and the medication is not beneficial. We may also have these individuals, not having toxic response to the medication, but the medication not beneficial. And we also have these individuals not having toxic response to the drug, but the drug being beneficial. And so we call this one size fits all medicine, where you give same medication to same group of people with similar diagnosis. But the concept of pharmacogenomics is the concept of personalized medicine, where we try to individualize drug therapy based on the genetic expression of individual patients. Now, the goals of pharmacogenomics are basically 4, which I will also call the benefit of pharmacogenomics. 1, with pharmacogenomics, we can maximize drug efficacy. And I give an example with the use of codeine. Codeine is an opioid analgesic, which is known as a prodrug. And codeine must be metabolized to morphine before we have the analgesic effect. And the specific metabolizing enzyme that will convert codeine to morphine is cytochrome P2D6. And there are patients who are deficient in this genetic enzyme that will not be able to metabolize codeine to morphine, and they will not have the analgesic effect. But with the concept of pharmacogenomics, we're able to determine the genetic sequence, the expression of patient, and we're able to place patient on appropriate medication that will maximize drug efficacy. At the same time, with the concept of pharmacogenomics, we can minimize drug toxicity. And I also give an example of privaquine, being given to a patient who is deficient in glucose 6-phosphate dehydrogenase, and patient are having hemolysis. This is an adverse effect which occurred in this patient because of inappropriate genetic analysis, to determine the genetic expression of the patient, to know that the patient is deficient in glucose 6-phosphate, and primaquine will not be a good candidate for that patient. We can also use the concept of pharmacogenomics to predict patients who will respond to intervention, just like I said earlier. And even in the course of new drug development, we use the concept of pharmacogenomics. Of course, we can have modification of drug molecules, that will be suitable to interact with appropriate genetic expression of patients that will give maximum efficacy. Now, having said that, the 2 terms that are usually used interchangeably are pharmacogenomics and pharmacogenetics. In simple and clear terms, pharmacogenomics is just the study of genomic influence on drug response. Genome is full of genes, while pharmacogenetics is influence of individual gene on drug response. And for us to have good understanding of pharmacogenomics, we must also have some level of understanding of molecular biology, of pharmacology, therapeutics, and toxicology. There was a project I will call Human Genome Project. And that project was with the intention to do a complete mapping of human genes. And that project started in 1984 and was completed in 2003. After the completion of that project, we realized that human beings have about 20,500 genes. And that will tell us how complex the concept or the field of pharmacogenomics is. And all these genes are expected to interact with drug molecule to give a response. Now, we also have the understanding that human beings are identical up to 99.9% at the DNA level. But the remaining 0.1% give account of over 3 million differences at the DNA level, which we also account for our differences in appearance, in behavior and in susceptibility to disease, and a response to medication, which will be the subject of today. Now, on the screen, we have the structure of the DNA. We all know that DNA is double helix structure. And in DNA, we have a sequential arrangement of nucleotide bases, purines and pyrimidines, arranged in sequential order in the DNA. But within the DNA, we also have the possibility of single nucleotide polymorphism. That is when there is alteration in the sequential arrangement of these nucleotide bases within the DNA. We can have thymine substituting adenine, adenine replacing guanine, which will alter the sequential arrangement of these nucleotide bases in the DNA. And when this happens, we refer to it as single nucleotide polymorphism. Of course, when there is polymorphism at the level of the DNA, it will affect the transcription of DNA to RNA. It will also further affect the translation of RNA to proteins, to enzymes, to microtubules. And we also know from our background that most drugs will interact with enzymes, with proteins, with microtubules to affect their response. Now, this is what we call DNA dogma. Like I said earlier, DNA will undergo transcription to RNA, okay, and RNA will undergo translation to proteins, to enzymes, to microtubules. So just like I mentioned earlier, anything that will affect the translation of RNA to proteins, to enzymes, to microtubules will also affect the interaction between this agent and drug molecule, and that will affect the response to that drug. And so this occurs at variation from patient to patient, and that will also affect the drug response from person to person. Now, DNA having the potential to undergo transcription to RNA, RNA is a single-stranded copy. And RNA will later give proteins, and in proteins you have amino acid. The important point I want to make on this slide is that amino acids are usually made of triplet nucleotides. Like I said, nucleotides are purine, pyrimidine, which are adenine, guanine, thymine, cytosine. So amino acids are made up of triplets of nucleotides. And anything that will affect the nucleotide in the amino acid, of course, we also affect the formation, okay, of amino acid from this nucleotide. And the next slide will clarify what I just said. Now you can see from this slide where we have adenine, thymine, guanine. Those are three nucleotides forming methionine. We also have cytosine, thymine, forming proline. And when there is single nucleotide polymorphism, changing cytosine to adenine, instead of proline, we have troline. And this will affect the interaction between drug molecules and amino acid, and we also affect the response to that medication. Now, these are basically four typical pharmacogenetic traits that we have. We have N-acetylase transferase, which is NAT2. And we know that when patients are deficient in this genetic enzyme, that will lead to slow inactivation of isoniazid and dapsone. And that could lead to drug accumulation in the system, which will eventually lead to drug toxicity. And we also know that about 45 to 65% of Caucasians are deficient in this enzyme. And about 10 to 15% Africans are also deficient in NAT2. We also have serum pseudocholinesterase. Of course, when patients are deficient in this enzyme, there will be prolonged respiratory paralysis on exposure to samethonium. The samethonium is an agent used as an anesthetic agent. And when there is a prolonged respiratory paralysis, of course, that will also affect the recovery of patients from the anesthetic agent, and that could lead to the death of the patient. And we also have from record that about 1 in 2,000 Caucasians are also deficient in serum pseudocholinesterase. We also have glucose 6-phosphate dehydrogenase. And when patients are deficient in glucose-6-phosphate dehydrogenase, we have hemolysis from antimalaria, especially primacoin. And we have statistics that 1 in 100 Africans, Americans are deficient in this enzyme. We also have tau purine methyltransferase. And when there is deficiency in this enzyme, there is bone marrow toxicity from antineoplastic agent mercaptopurine. And we also have data that 2% of population have low expression of this enzyme, 20% medium expression, and 70% high expression of tau purine methyltransferase. Now, if you look at the figure that we have on the screen, it's given two illustrations. The first one is showing 3 patients placed on cis-mercaptopurine without having the understanding of the expression of their tau purine methyltransferase enzyme. And that now resulted in variation in systemic exposure and variation in drug toxicity. But if you look at the figure below, the concept of pharmacogenomics, now put into the drug therapy by analyzing the expression of this tau purine methyltransferase in this patient. And so the doses given to this patient were also titrated. And you could see the patient having almost equal level of systemic exposure and equal level of drug toxicity. Now, the point I'm trying to make here is that when the tau purine methyltransferase level was determined in this patient, they could also determine the appropriate dose to be given to this patient, and that's also adjusted the level of systemic exposure and the toxicity of this patient to cis-mercaptopurine. Now, we have challenges in clinical practice, okay? And the major one is that we have individual variability in drug efficacy and drug safety. You place patients on same medication. Some patients will come with good response, while others will have poor response. All right, you place patients on same medication. Some patients will develop adverse drug reactions. Some will not develop adverse drug reaction. And from this table, we can see that anti-diabetic agents have about 57% efficacy rate. Anti-asthmatic agents have about 60% efficacy rate. And that also tells us that we have variations in response to these agents, from patient to patient. And that means the aspect of pharmacogenomics is important for us to be able to determine the genetic expression of patients and know the appropriate medication to give to this patient that will give maximum efficacy and maximum response. Now, like I said earlier on, a patient developing adverse drug reaction, because of the medication, that the patient take. We have from literature that about 7 to 30% of hospitalized patients in Europe were admitted due to adverse drug reaction. And we have about 40,000 to 100,000 deaths every year due to adverse drug reaction. And we also have from record that from 1975 to 2000, over 10% of newly approved drugs were withdrawn from the United States because of adverse drug reaction. And we know that most of these adverse drug reactions were due to idiosyncratic reaction. When we talk of idiosyncratic reactions, these are reactions that have genetic undertone. So if you're able to understand the genetic expression of patients, we'll be able to avoid this adverse drug reaction. And if you look at this chart on the screen, it tells for a drug to get to the market about 15 years and spending over $800 million. And for pharmaceutical company to go through this rigor and having the drug withdrawn from the market because of adverse drug reaction, that's a colossal loss. So the concept of pharmacogenomics is important, both at the clinical practice and even at the point of drug development. These are factors that are known to affect drug response. Where we have factors around administration, medication error, patient compliance. We have factors around pharmacokinetics, factors that will affect absorption, distribution, metabolism, and excretion. We have factors around pharmacodynamics, factors that will influence drug receptor interaction. In this presentation, I will be looking at some aspect of metabolism and drug response, drug receptor interaction. Now, in drug metabolism, we currently know that there are more than 30 families of drug metabolizing enzyme. Of course, if there are 30 families, that means different patients, expressing different cytochrome P450 alleles, metabolizing enzyme. And we also know that about 3/4 of white and half of blacks have a genetic inability to express cytochrome 3A5. And the lack of expression of cytochrome 3A5 is not evident because most of the drug that 3A5 will metabolize, cytochrome 3A4 will also metabolize those drugs. But the implication of this is that when patients are placed on drug that will be specifically metabolized by 3A5 and the patients are deficient in this enzyme, of course there will be drug accumulation. Drug accumulation leading to drug toxicity. Drug toxicity will also affect, even the response of the patient to that drug. And so for medications that are equally metabolized by both enzymes, the rate of metabolism is the sum of that due to 3A4 and 3A5. That's another implication, that when you now have patients expressing both 3A5, 3A4, and they are placed on the drug, that 3A5 and 3A4 will metabolize, there will be extensive metabolism, which could also lead to therapeutic failure of that drug. Now, this is a table showing some cytochrome P450 variants, and the percentage of drug metabolized and the substrate. Cytochrome 2C9, it has about 10% of drugs that enzyme metabolize, and these are warfarin, ibuprofen, diclofenac. Cytochrome 2C19 has about 25%, and the examples are amitriptyline, diazepam, omeprazole, imipramine. 2DC has between 20 to 30%, and the examples are codeine, clozapine, imipramine. The important point that we need to pick from this table is that we have specific cytochrome P450 alleles for specific substrates of drugs. And if a patient is not expressing the appropriate cytochrome P450 alleles, the patient will also not be able to metabolize that drug, and that there will be implication of drug accumulation. And also, if patients are expressing two types of cytochrome P450 alleles that will also metabolize same drug, there will be extensive metabolism, and that could lead to therapeutic failure. Now, this is also an important slide showing cytochrome 2DC. Like I said earlier on, this is the major metabolizing enzyme for codeine. Okay, so if patients are deficient in this enzyme and they are placed on codeine, they will not be able to metabolize to morphine, which is the active metabolite, that will show the analgesic effect. And also, when patients are deficient in cytochrome 2DC, there will be increased toxicity of antidepressant agents, of course, because of inability to metabolize antidepressant agents, causing drug accumulation in the system and leading to drug toxicity. But this is another table that is showing cytochrome P450 enzymes and their substrate. Of course, that could be explained using the earlier explained fact that will have different patients expressing different alleles of cytochrome P450, and when they are placed on medication that is unable to be metabolized by the enzyme that they express, there will be accumulation, or when they are placed on medication that they have dry enzyme that can metabolize medication, that will lead to extensive metabolism, and that will lead to therapeutic failure. Let's take, for example, if when patients are expressing cytochrome P1A1 and 1A2, and the patient is placed on caffeine, of course, there will be extensive metabolism of caffeine, which could lead to therapeutic failure. And also, if patient is expressing 1A1 and 1A2, and that patient is placed on erythromycin, for example, but there will be inability to metabolize erythromycin, which could lead to drug accumulation, adverse drug reaction, and drug toxicity. We also have the aspect of drug interactions with cytochrome P450 enzymes. And I want to take the last example here to make a particular illustration. The patient expressing cytochrome 3A4 and is placed on felodipine and concurrently placed on grapefruit. Grapefruit is an enzyme inhibitor, specifically it inhibits 3A4. And so there will be accumulation of felodipine because of the inhibition of 3A4. And that will also lead to adverse drug reaction. And this figure is further illustrating that. We have situation where patient is placed on felodipine and some of them concurrently placed on grapefruit, whereas others, not on grapefruit. Those that are placed on grapefruit, we could see an increase in plasma concentration because of the accumulation of felodipine in the biological system. And those without grapefruit, we could see a decrease in the plasma concentration. Now, the risk of enzyme inhibition, enzyme inductions, as projected on the screen. When there is enzyme inhibition, there is also tendency for a decreased degradation of co-medicated drug. There could also be an increase in drug plasma concentration, and that could lead to risk of severe adverse events. For drug induction, when there's an induction of cytochrome P40 enzyme, there could be an increase in degradation of co-medicated drug. There could also be a decrease in drug plasma concentration, which could lead to loss of pharmacological effect and risk of therapeutic failure. Now, this is about drug target. We said that, of course, most drugs without receptor to elicit their pharmacological action. Patients with beta-2 receptor arginine genotype have been documented to experience poor asthma control, while patients with beta-2 receptor glycine have also been documented to experience good asthma control. In other words, when patients are placed on beta-2 adrenergic agonists, for example, salbutamol, and the patients express beta-2 receptor arginine, there is likelihood that the patient will have poor control of asthma, okay, because of non-responsiveness of the receptor to the drug. But if the patient expresses glycine as a beta-2 receptor, there's also tendency that the patient responds well to the drug and there will be good asthma control. Now, we also have polymorphism in vitamin K lipoxide reductase, of course, to warfarin. Basically, warfarin is known to inhibit vitamin K lipoxide reductase to give you an anticoagulant effect. But there could also be polymorphism of this enzyme. Of course, that will also affect the anticoagulation effect of warfarin, which would differ from patient to patient. And we also have a patient expressing human epidermal growth factor receptor 2, which have been known to benefit from monoclonal antibody trastuzumab. But patients not expressing this will also respond poorly to monoclonal antibody trastuzumab. So the essence of pharmacogenomics is to do a complete genetic mapping of patients so as to determine the appropriate medication that patient will respond well to. Now, we can also see from the table below the interaction between aspirin and glycoprotein 3A subunit. Of course, aspirin we know to inhibit glycoprotein 3A subunit to give it antiplatelet effect. Glycoproteins are basically on the platelets. And so there are also polymorphism variant of glycoprotein 3A, which will determine the antiplatelet effect of aspirin when patients are placed on this drug. The same thing applies to bradykinin B2 receptor. AC inhibitors, of course, are known to inhibit bradykinins. When there's inhibition of bradykinin, there is increase in the level of bradykinin, which will interact with the cough receptor center. And that is been known to cause AC inhibitor-induced cough. But it now depends on the level of expression of patients, to bradykinin B2 receptor that will determine whether AC inhibitor will induce cough in those patients or not. And so the concept of pharmacogenomics is to precisely be able to do a complete mapping assay of genetic expressions of patients, so as to be able to determine the appropriate drugs that the patient will respond to, and also be able to minimize adverse drug reaction. Let's also take codeine and tamoxifen as a case study, just like I explained earlier on. Codeine, which is an opioid agent, a prodrug, must be metabolized to morphine for its activity, and the major metabolizing enzyme is cytochrome 2 disease, which have been documented to be deficient in 7% of Caucasians. And of course, these patients will not do well on codeine as an analgesic agent. The same thing applies to tamoxifen. Thermospan is also a drug that will be converted to endorphin for patients who have the benefit of the antineoplastic effect. And this is basically metabolized by CYP2D6. And also we have from record that 6 to 10% of European population are deficient in this enzyme. And of course that will affect the response of this patient to tamoxifen. And so alternative drug is better given to that patient to have a good therapeutic outcome. Now, there are limitations to pharmacogenomics. And the major one is the cost factor. Cost factor, access to genomic technology, especially in the developing country. This could be expensive, for patients to have their total genetic mapping, so as to determine the appropriate drugs that the patient will respond efficiently to. So cost is a major limiting factor. Apart from cost, we also have factors of confidentiality. Once there is total genetic mapping, of course, the patient will have the mapping in the case file, which of course could be revealed to some health insurance people, and that could also predict the disease that this patient will be susceptible to. And so the health insurance may not want to take up this patient because of the information about their genetic profile. So it's also a limitation to the practice of pharmacogenomics. But having said that, the outcome of pharmacogenomics basically will ensure that we give the right dose of drug to patients. It will also ensure that we give the right drug to right patient and right indication, and also giving the right medication to right patient, which will come together to improve the therapeutic outcome of the patient. In conclusion, I want to say that pharmacogenomics is expected to lead to better and safer drugs, as explained, and more accurate methods of determining appropriate drug dosages will be achieved with the concept of pharmacogenomics. And we think that in the future, it's likely that patients will have complete mapping of their genetic profile at birth, which of course could be in the electronic form in the record, so as to be able to know the appropriate drugs to be given to this patient. And that will improve drug therapy. I want to say thank you for listening, and I hope I've been able to make it clear that the concept of pharmacogenomics will enhance drug therapy, will improve drug therapy, and will reduce adverse drug reaction to medication. Thank you for listening.